Okay, good afternoon all. Today the topic is preterm labor. You have seen that preterm labor. Preterm labor means that the baby is not able to complete the term. That is the full term means of 40 weeks, 9 months, 7 days. That is the 40 weeks. If the baby is not able to complete, then we can say that the baby has born as a preterm baby or premature labor. This is called the preterm labor. Definition of labor. It's a series of events that takes place in the genital organ in an effort to expel the viable product of conception out of the womb through the vagina into the other world is called as labor. You have seen this definition in labor, so no need of much explanation. Then coming to the premature labor. So preterm labor can be defined as regular uterine contraction that causes progressive dilatation of the cervix after 20 weeks of gestation and 37 week of gestation. Preterm labor we can define as a regular uterine contraction that causes progressive dilatation of the cervix after. There will be progressive dilatation of cervix after 20 weeks of gestation and 37 weeks of. After 20 weeks and 37 weeks also there will be regular course of contraction, uterine contraction will be occurs, and that the cervix progressive dilatation, the cervix will dilate and have the tendency to deliver. Then in this between 20 to 37 weeks, in between this period, any time that the labor occurs, we call as a premature labor. It is one of the leading cause of prenatal morbidity and mortality. Before 37 weeks, you can say as premature labor or preterm labor. Okay. Then incidence. The premature labor affect almost 32% of pregnancies in India. Recent in India, 5 to 18% developing country in India. Then pregnancies in developing countries in India, Africa and South Asia, 60% premature babies develop. Europe 5 to 9%. Types: late preterm labor, 34 to 37 weeks. That is 71.2%. Very preterm labor, 30 to 34 weeks. Then extremely preterm labor, 24 to 30. We can divide the preterm labor into three types, that is the late preterm labor, very preterm labor, extremely preterm labor. Then etiology, that are the causative factors. First one, 50% is causes unknown. Then next, infection, multiple pregnancy, preeclampsia, placenta previa. Placenta previa you may study later, that is the here also I will explain with the figure. Then abruptio placenta, that also I will explain. Then polyhydramnios, that is the fluid level is high, that is amniotic fluid level is high, more than 2000 ml. It is then oligohydramnios, below 500 ml. It is the fluid level is less. Then maternal disease, that is the maternal disease, that is the heart disease, gestational diabetes, preeclampsia, like that is maternal diseases. Then maternal stress, then smoking and alcohol abuse, uterine malformation, maternal age, uterine malformation we have studied in gynecology. Then ischemia. Then this is the abruptio placenta. You see the abruptio placenta. The placenta is separated from the uterus. You see the placenta has separated from the uterus. The placenta is attached. Normally the placenta is attached to the posterior or anterior position of the fundus, that uterine fundus. Then if there is, it is detached, the uterus is attached, the placenta is attached over the fundal region of this. The uterus is detached from the placenta is detached from the uterus. This is called as the abruptio placenta. And then after that, in some cases there will be internal bleeding will be there. That is this is called as scolar uterus. Then coming to the placenta previa. See the normal. So that is how the placenta is attached. Then the baby is lying, that is longitudinal lie. Then the cephalic presentation is there. Then here you can see the placenta previa, that is the placenta is normal attachment of the placenta. The placenta is is attached below, that is fully covered the cervix. Okay, this is the placenta previa and abruptio placenta. Then risk factor: short maternal height and weight, long working hour, short cervical length. Cervix length is very less. That also I will explain later with the figure. Low socioeconomic status, racial, previous abortion. Then one spelling mistake is the previous. Poor nutrition, domestic violence. Then coming to the pathology. Pathology, you may see, can see maternal stress and fetal stress. That is uteroplacental insufficiency, fetal stress that occurs. Then maternal stress, that is the activation of maternal HPA axis. HPA means hypothalamic pituitary axis. Pituitary, that is the hypothalamic. Then that is the this cortisol hormone will be releases. That is threefold. That is the hormone will be releases. Then the steroids, glucocorticosteroids will be more. Glucocorticosteroids will be occurs. In that condition, that the mother is getting more stressed during this time, and if the mother is getting more stress, these hormones will be occurs, more hormones will be producers, and these cortisol hormones will be producers due to the activation of hypothalamic pituitary axis. The hormones will be producers. Then here that is it will be affect to the baby also, fetal stress also will be occurs. That is why we are saying during the pregnancy time, mother should be calm and cool, relieve anxiety, stress, that all. If mother is getting more stress, these hormones will be occurs, and this is a one factor for getting preterm labor and also coming for other complications. Okay, then this cortisol, this increase that amnion and PGDH in hormone and decidual placenta membrane. Then CRS, there will be the increase. Then prostaglandins will be releases. Then due to that prostaglandin will be releases. There will be contractions occurs, cervical changes, cervicals will become starts to dilate. Then myometrial OTR, PGC, MLCK, calmodulin, gap junctions. These are all the hormones that will be releases, and rupture of membrane will be occurs. In fetal stress also, this activation of this HPA, ACTH, adrenal, DHAS, and the placenta and the membranes, estrogen will be produces. Okay. Then signs or symptoms: backache, lower back pain, contraction every 10 minutes, cramping, fluid leaking from vagina, fluid like symptom, nausea, vomiting, diarrhea. Investigation: history collection, physical examination, blood study, urine analysis, cervical culture, transvaginal ultrasound, fetal fibronectin evaluation, fetal surveillance study, drug screening. And coming to the management, pharmacological management, maternal administration of corticosteroid is advocated in the pregnancy less than 34 weeks. If the mother is less than 34 weeks, we can administer corticosteroids. Then betamethasone 2 dose, dexamethasone, magnesium sulfate for the brain development. Then antibiotic to reduce the infection. Initially use of tocolytic agents that suppress the uterine contraction for an acute episode of premature labor. Nifedipine, terbutaline, then retrodine, then isosurin, endomethacin, nitroglycerin. Then expectance treatment: progesterone given patient with a history of premature labor. Progesterone injection administration is weekly, 10 to 20 weeks of gestation. Then surgical management. I had told the short cervix, that is the cervical circlage. That is, we are doing cervical circlage, a surgical procedure that closes the cervix with stitches to present the cervix form. From this cervix, the loose avadirikan circle. You see the picture. circulation correction is of the cervix. The nursing management, assess the mother condition to evaluate signs of any labor, that is obtain obstetric history, determine the frequency, duration and intensity of uterine contraction, determine the cervical dilatation and effacement of the patient, assess the status of the membrane and blood show, then place the client on bed rest in the side-lying position, prepare for possible ultrasonography, amniocentesis, tocolytic therapy or steroid therapy, administer tocolytic agent as prescribed, assess the patient level of anxiety. Then immediate management, the cord is to be clamped quickly, the airway should be cleared, provide adequate oxygenation, aqueous solution of vitamin 1 mg given IM to prevent hemorrhage, vitamin K. The baby should be warped for sterile warm towel for fetus and death for hand over the lattice. The fetus who are dead, we should hand over to the lattice. Provide NICU care of the baby. Then flow chart of management, preterm labor. Then first we should be that is 24 to 28 weeks, counseling for vaginal delivery, search for the cause, the fetal multiple infection, then 32 weeks, then about the period that if the signs and corticosteroids and antibiotic. Then if it is a breech by cesarean section, if not, then 28 to 32 weeks, give tocolytic oral therapy. If IV successful, corticosteroids can transfer to tertiary pregnancy center, cephalic, then go for vaginal delivery. If it is not able, then go for cesarean section. Okay. This clearly it has given on your Datta textbook, that is the flowchart of management that you can add. Then prevention, identification of the risk factor from history and employing measure, provide nutritional supplement, avoidance the substance abuse and smoking, detect the medical risk, provide adequate rest, assess the domestic violence, avoid the heavy burden during pregnancy. Complications are maternal complications, severe preeclampsia, heart disease, placenta previa, abruptio placenta, intraamniotic infection, uterine malformation, fetal complication, fetal death, respiratory distress syndrome, intraventricular hemorrhage, neurological problems, cerebral palsy, growth restriction, fetal anomaly, incompatible with life, neonatal jaundice, brain injury. Okay, thank you all.